So moving into earlier stage disease, every drug in oncology is first tested in the metastatic and late stage setting, and then we start seeing it creeping up into earlier and earlier stage disease to see if we can cure more patients. So we've got in the patients who are getting concurrent chemoradiation, we've got 2 studies that are out there and have been presented at ASCO, and we also were presented at World Lung. Now, one was a large phase 3 trial, the Pacific trial, that compared durvalumab for 1 year compared to placebo in patients following concurrent chemoradiation therapy. So patients were randomized immediately after chemoradiation. And then we have the LUN 14-179 from the Hoosier Oncology Research Consortium that looked at consolidation pembrolizumab in a similar patient population. So we have a drug that's FDA approved, but pembrolizumab is out there. How are you using these drugs? Which drug are you using? What are you doing for patients with early stage disease?
So for the stage 3, I generally do the chemoradiation, then do the durvalumab, because that's the thing that's been proven to have a progression-free survival, overall survival benefit, and time to distant metastases. Also, the toxicity is established as well. I've not interchanged PD-1, PD-L1 inhibitors in the stage 3 setting, and I'm not prepared to do so.
And I agree. The data that we do have robust data with durvalumab in this setting. And although the Hoosier Oncology Group study is obviously an impressive study, we don't have the same regulatory approval, all of the things that go along with that. So I certainly have used durvalumab in that setting.
And hopefully that rumored is also going to start coming out monthly, and hopefully when we have that data, that'll also make it a little bit easier to give those patients. How quickly are you starting durvalumab? In the subset analysis, it said maybe if you start less than 2 weeks, there's a better survival than if you start later. Are you starting patients at 2 weeks? Are patients ready to start after 6 weeks of concurrent chemoradiation therapy?
I think this may be a discrepancy between a clinical trial population and a traditional population. I think that in fit, healthy patients that are otherwise in shape to do it in that period of time, I would. On the other hand, I am less convinced about that it's absolutely necessary, and on a practical level, there is a large chunk of our patient population where it's just not really feasible.
What happens if they're out at 7 weeks, 8 weeks? Because that trial, we had that study open. I don't know if you had the trial open at your institutions, but it was a 6 weeks hard stop from when concurrent chemoradiation finished. So what happens if someone needs a little bit of extra time? They're at 7, 8 weeks. What are you doing?
So I don't feel strong about the 14 days, but I feel the 42 weeks is 42 days or 6 weeks is I'm pretty firm on that one. I'm not saying like 7 weeks would be bad, but I think what you're really trying to do with that is make sure that the patients tolerated the chemoradiation therapy without serious toxicity. And most of the people who are delayed have either radiation pneumonitis or bad esophagitis, and I'm somewhat hesitant to add a therapy on when they haven't recovered from the previous therapy. Is one of my concerns.